And I will now request Dr. Leenath to give his talk, to address the question: does plasma exchange actually save lives in patients with rodenticide injection? So, Leenath, if you can take over. Yes, it's visible now.
Okay. Good evening, everybody. Thank you for the opportunity to present the study that we had done in the last year. So this was accepted for publication in the Journal of Clinical and Experimental Hepatology. So the title of the article is Improving Transplant-Free Survival with Low Volume Plasma Exchange to Treat Children with Rodenticide-Induced Hepatotoxicity. Now, so rodenticide, as we already know, it has become a major cause of hepatotoxicity and death in the young. And the definitive treatment for the acute liver failure is only doing an urgent liver transplantation, because there is no antidote as of now available. And the criteria specifically for rodenticidal hepatotoxicity is the Kochi criteria, which was given by a group in Kochi, Amrita Kochi, some few years ago. And the aim of the objective of the study was to describe our experience with low volume plasma exchange to treat children with rodenticidal hepatotoxicity. This study was the retrospective study of all the patients who were admitted in the Department of Hepatology in CMC from December 2017 to August 2021. And the patients were categorized into two groups. One is those with acute liver injury, that is, has abnormal LFT along with the coagulopathy. The other group of patients were acute liver failure, those with coagulopathy and also having encephalopathy. The Kochi criteria was the criteria used for considered for the used for transplantation criteria. It was MELD more than or equal to 36 or a baseline of INR of more than 6 with encephalopathy. The outcome was, primary outcome was looking at the 1 month survival. Now, this is the flow diagram of the patients. We had 110 patients with rodenticidal hepatotoxicity during the study time. Of that, 78 were adults and 32 were children, that is less than or equal to 18 years. Of the 32, 20 had the acute liver injury and 12 had acute liver failure. And of the 20, one met the Kochi criteria for transplant and 19 did not. That is the acute liver injury. Of the acute liver failure, 9 met the Kochi criteria. So totally 10 children met the Kochi criteria of liver transplantation. And the plasma exchange was done. I'll come to the results again later on. Now, this was the baseline characteristics. If you look at here, this second column is the acute liver injury and third is the acute liver failure. The age was, the median age was 16. The youngest age was a child who was poisoned by the mother along. So she and the child, it was 4.5-year-old. The oldest were 18. In the acute liver failure group, the youngest was 7.5-year-old. This was a child who accidentally consumed the rodenticide without knowing what it was. 50% of the liver injury patients are females, 67% was in the acute liver failure was females here. Now, about the treatment details, so once the patient comes and once they are eligible for a liver transplant, once they come into the criteria for liver transplantation, we opted them, but none of the patient family had the option of a liver transplantation. All of them were given standard medical care, including N-acetylcysteine, and acute liver failure patients also got the anti-cerebral edema measures. So totally, of the 32, 17 children had plasma exchange. Of that, 6 was acute liver injury and 11 were acute liver failure. The median number of sessions was 3, ranging from 1 to 5. The volume was 26, around 20, the median was 26 ml per kg. We started plasma exchange by a median 2 days of admission of hospital with a range of 1 to 4. And we did not find any major complication. 2 children had a bit of hypotension at the beginning, but they were managed with IV fluids and few hours of inotropes. Now, this particular table shows the comparison of 1 month survival in children as well as in the adults during the same study time. So 10 children met Kuchi criteria, 9 underwent plasma exchange, and we have the TNISG criteria for eligibility. Of the 8 were eligible. Of the 8 eligible children, 6 survived with plasma exchange. That is, the survival was 75%. And at the same time, adults also, there were 57% survival. So altogether, there was a 88% survival in the children. Now, there were some, the children with the liver disease, liver failure and liver injury had some extra hepatic complications as well. 9 of them had more than or equal to grade 2 hepatic encephalopathy. Nearly 90% of them survived without any problems. 9 of 9, that is nearly 30% had acute kidney injury. All of them survived. 5 of them had bacteremia, and all of them survived. Mechanical ventilation was given, but only 1/3 of the patients survived. So more than 9 of them, 10 of them had more than or equal to more than 1 complications, and more than 2/3 survived. So this table compares our study with the original group which gave the Kuchi criteria, that is the Saraf et al. Group. So in the patients who are less than 18-year-old, the survival was 75%. That is, those who underwent PLEX and were eligible. More than 18 years, the survival is 56%. So the combination is 59. At the same time, without plasma exchange, so the Saraf et al. Group had 22 patients. Of that, 22 had met the Kuchi criteria. Of that, 8 got the standard medical care, and none of them survived. 12 of them got 14 of them got liver transplant, and 12 survived. So definitely we have noticed that PLEX, low volume PLEX, improved survival without liver transplant in children with rodenticide hepatotoxicity who met the Kuchi listing criteria. And this picture shows the summary of what I have already shown now. So 75% survival. Thank you.
Thank you, Leenath, for your presentation. And this has now been published. This is available on the net, this information. Now, it is always difficult to interpret the survivals on the sick patients. And this sort of analysis which has been done is waiting to be done in bigger data sets. For example, there's a lot of information now with the intervention done by NHM. And I'm grateful for Dr. Marduture and Lydia for having joined today's meeting.